Hi, welcome to the 26th Annual Alamo Advocate Program. I'm your moderator, Jerry Francor. I'm a two-time breast cancer survivor, first diagnosed in 2003 and then again in 2020, and I've been part of Alamo since the early 2000s. We're trying something new at lunch today. This is our first lunch and learn on busting myths on imaging across the breast cancer spectrum. My career actually started in imaging, and I find it ironic that imaging is one of the first modalities we use to screen and diagnose for cancer, but it's only been in the last couple of years that it's really come to the forefront at conferences, so I'm really excited about it. Before our panelists introduce themselves, there are a few housekeeping notes. Please make sure your phones are all turned off. I want to thank our sponsors. They are Exact Sciences, Genentech, Merck, Novartis, Daiichi Sankyo, GE Healthcare, Menarini and Stemline, Seagen, Lilly, Pfizer, Eisai, Viatris, the Joe W. and Dorothy D. Foundation, and the Cooperative Foundation, and our production company, CMP. All our panelists, they went too fast for me. Some more of the housekeeping tips. When we get to the question and answer session, please step to the mic to ask your questions. Please only have one question, and then you can go back to the end of the line to ask another. Please do not ask about personal issues. If you want to talk to our panelists afterwards, that's fine. But keep your questions to imaging. We're streaming live, so there's going to be a hard stop when we have to stop because I get the cutthroat sign. So if you have any questions, they'll be available afterwards so you can come up and talk to them. Also, please fill out the evaluations online or on the table. I think they're out there. And it will help us determine whether this was a good thing having an Alamo-sponsored lunch and learn session or whether you didn't like it at all. We want to know. But be sure to come back tonight for our hot topics session. And first, I'm going to introduce Dr. David Mankoff, and he will start the presentation.
And do we want to do all the introductions or introduce as we go?
As you go.
Okay, great. And I think I'll do this sitting down if that's okay. I'm David Mankoff, and for those of you that were part of the Hot Topics last night when I was also here, thank you for coming back again. I am a physician investigator, a nuclear medicine physician investigator at the University of Pennsylvania. I also started my training and career as an instrumentation physicist and engineer, and so that although I'm not quite the level of engineer and physicist I used to be, I'm going to start today's lecture with an introduction to some of the physics of the overall approach, how these systems work, and then I'll concentrate pretty quickly on PET scanning and turn it over to Amy Fowler to tell us a little bit about the broad spectrum here, including PET. We'll then pass it on to Martin Tournai, who is a bona fide physicist, who'll talk a little bit about the physics of single photon imaging and molecular breast imaging. Maya Rausch will talk about the actual imaging process, and Leslie will bring us home on talking about density matters. So that's the outline for today, and this is my first slide. So if we think about diagnostic tasks in breast cancer care, and in particular those tasks that involve some sort of imaging, the steps that many of you are probably already familiar with are the detection or screening, where we're asking the question in patients who otherwise don't necessarily have a reason to have a suspicion to do screening and look for the possibility of lesions that will need further workup. There's the closely related component of diagnosis where you have a reason, either on the basis of physical exam or screening mammography or something else, that there may be a lesion there that might be a cancer. And so you're asking the questions, is this lesion a cancer? Where should we biopsy? And how big is this cancer? Now, I'm showing you some images from the different modalities that are there, and you'll hear more about this from Amy and others. Those two tests are an area where things like ultrasound and mammography and MRI have been around. And you'll see a little picture all the way over to the right there that is molecular breast imaging that you'll hear a little bit more about in the second half of the talk. Once you have a diagnosis of a cancer, The next question is, how far has the cancer spread? Number one, within the breast, that has been part of the original diagnosis workup in most cases. Has it spread to the lymph nodes, both in the axilla and other parts of closely related nodes? Has it gone to distant sites like the bones, the liver, the lungs, and other places that it can go? And this is a place where we've often used things like CT, but we also use nuclear medicine molecular imaging tests such as bone scanning and also PET scanning, as you'll hear about a little bit later. Once we know we have something that has to be treated, either locally advanced breast cancer or metastatic breast cancer, a big question comes, how is this tumor responding? And increasingly, nuclear medicine and especially PET is playing a role, especially in many patients that have bone metastases, which have been otherwise difficult to characterize. And then finally, as you heard for those that came last night, it's a relatively advanced process right now, but we're beginning to not only tell you whether or not something's there and how it's responding, but actually characterize it. And in particular, there's an approved agent that can tell you about whether or not your tumor expresses estrogen receptors from an imaging test in complement to pathology. All right, and I'll go forward. So again, I'm going to leave the slide up just for a short period of time. You'll hear more about it. You're familiar with things like mammography and its close cousin, digital breast tomosynthesis. Those work by X-rays, which will take a picture based upon density. Ultrasound works by sound waves. And CT is, in essence, an X-ray technique that works by fully three-dimensional reconstructions by going through a tube, and these all are typically found in fairly anatomically oriented processes. There are methods that give you both anatomical and functional information such as blood flow, abnormal permeability through the kind of blood vessels that are associated with tumors, and that has thus far been largely MRI with contrast. And these are radio waves that come from electromagnetic energy. There's some early work on using contrast for mammography that can give you some of the same functional information. What we're going to talk about mostly today is what we call SPECT, single photon emission computed tomography, or PET, positron emission tomography, big mouthfuls. They are radiopharmaceuticals. These are drugs that are used for diagnosis for the most part, but they can be used for therapy and are tagged with radioisotopes. Now, as creepy as that sounds, we're going to tell you that it's actually a pretty safe and low dose process as we go through. And what we emphasize here is that you get information that you can't get from other imaging studies. Right? So we're going to concentrate on that box on the bottom. All right, this slide illustrates a couple of things. One is I better keep my day job as an imager and not be a medical illustrator. But the way this works in general is you usually inject something and the patient's always smiling and it's red and it's hot. They go under a specialized device that is really a very sophisticated radiation detector or radiation detection system. And then we actually get a spatial image of the tracer distribution. So we can not only count how much tracer has gotten there, we can take a picture of it. So it's an image of the radiopharmaceutical distribution, and we image the process that radiopharmaceutical was designed for. And you'll hear more about that later. Now, the special piece that we'll start with is a form of this called positron emission, or PET, positron emission tomography. A positron is an anti-electron, it's antimatter. It will travel a very short distance and annihilate, which is a physics term for canceling out mass and turning it into energy, Einstein's famous equation. And it gives you two oppositely directed photons, which make a very powerful imaging situation. Anybody heard about matter before? Any Trekkies? All right. So this is the same reaction. We haven't had anybody hit warp speed in a PET scanner, as far as I know, so far. All right, so when we do PET, we often use short-lived radioisotopes, and we actually often start the process in the day with an accelerator or cyclotron to be able to make the radiopharmaceuticals, which have a 2-hour half-life. We happen to do it under the nursing building in our campus. The nurses seem to be okay with that. Nobody gets radiated. And there's a number of commercial supplies. We then put them in a scanner that is a specialized system that detects these pairs of photons. It is usually coupled with a CT or an MRI. You'll hear a little bit more about that today, and it provides an image of tracer concentration. That's an important word from two standpoints. It's an image, and it gives us information about where this tracer is localizing that helps us identify the tumors. It's also a quantitative technique that tells us how much tracer got there, and that can be very important in applications to response evaluation and some of the characterization we do. So in my last slide, you go, okay, this sounds really crazy. You run this cyclotron, you make this radioactivity, you inject it to somebody. Do they turn into a giant spider and start shooting webs? They don't, unfortunately, otherwise more people would want to do it. But why is this? And the reason is that most of you are not or not particularly radioactive right now. So if we inject a very small amount of radioactivity, we can in principle detect every molecule that is labeled that has made it into your body. So it's a very sensitive, very high contrast system. And this is the concept of a minuscule biochemical dose. It is a little bit of the imaging Heisenberg's uncertainty principle. We can image your physiology and your biochemistry and your molecular biology without perturbing that. And right now, radiopharmaceuticals are pretty much the only way to do this. An example of this is an estrogen receptor PET. It's commercially called Cerianna. We call it FES or fluorestradiol. People go, oh my God, I'm trying to deprive my body of estrogen. Why are you giving me this? Well, the answer is we are giving you 1/1,000,000th of the amount of estrogen that would have been in place. And we're down to concentrations that are 1/1,000,000th of what are standard concentrations. And part of the reason we use radiopharmaceuticals is the reason that to get to that same level of contrast with any other device, we have to go up by a factor of 1,000,000. So PET can image biologic processes without perturbing them, and the radiation dose is really small. We need very few amounts of radioactivity, and so the radiation dose that you get from a PET scan is actually quite a bit lower than if you image the whole body with a fully diagnostic CT. So with that, I will stop. I think we're going to take questions at the end, and I will pass it on to my good friend and colleague, Amy Fowler.
All right. Thanks, Dave. Well, thank you again for the invitation to add to this discussion. And for my portion, I'll be focusing on molecular imaging after breast cancer diagnosis. So, all right. So the overview for my section really focuses on what's happening after a new diagnosis of breast cancer. So staging information, where in the body is breast cancer located? Is it just in the breast or has it spread outside the breast? What's the most appropriate treatment for a particular type of breast cancer? And how imaging can be used to help determine if the treatment is working or not working. So again, I'm just focused on a small portion of the entire spectrum of where we can use imaging. And so again, as Dave mentioned, imaging is very important for screening and early detection when treatments are most effective and cure is more likely. And you'll hear more about that from our remaining speakers today. Also imaging for evaluating a specific symptom that may be a concern for a potential breast cancer, including a lump or nipple discharge. And again, for many years, since 1989, we've actually seen decreases in deaths due to breast cancer, which is great. And this has been a combination of both early detection through screening mammography and also combined with new and better therapies, medical therapies, surgical therapies, radiation therapies. And it's this partnership together that is really making a difference. And as you've seen at the meeting today, while we're making good progress, we still have room for improvement. We need better imaging techniques, which we're talking about, and better therapies, which you've seen in the meeting. So again, just want to reemphasize that imaging can tell us, early on if something is suspicious or not and needs a biopsy, but we really work together with our pathologist colleagues after we do a biopsy, and the imaging together with the tissue biopsy is what's used for diagnosing a breast cancer. So again, now that we've got a breast cancer diagnosed, what happens for imaging after that? So staging, this is important again, to determine if the cancer is only within the breast or has spread potentially to lymph nodes in the armpit or axilla region, or has it spread beyond there into other areas of the body? And imaging helps answer some of those questions. Again, pathology and the tissue biopsy helps answer some questions about tumor biology. And all these information pieces come together to determine staging, which tells information on prognosis for the patient and also helps surgeons, medical oncologists, and radiation oncologists for determining the right treatment. So how specifically for imaging, what types of imaging tools do we have that help initially stage breast cancer? So typically, most patients have already had mammography and ultrasound. Those are definitely used first to tell how much involvement is there in the breast. For breast MRI, that's used sometimes, especially if the mammogram shows that a patient has dense breast tissue, which you'll hear more about later this session. And then when there's particular concern that there might be spread outside of the breast or axilla, then you would look at whole body imaging. So this is, again, a CT or CAT scan, bone scan, which we'll talk about, or PET imaging. And again, this is only for patients where there's a particular concern. So maybe a large size tumor, axillary lymph nodes, or if there's specific signs or symptoms worrisome for distant disease. So again, just kind of starting off with our bread and butter mammogram and ultrasound. This is a patient who was too young to start screening, so only 31 years old, who felt a lump in her left breast. And on the mammogram, you can see there's a lot of dense breast tissue. It makes it very hard to see where this cancer is located. You can see on ultrasound that the area is a little bit better seen, and that was biopsy-proven breast cancer. And then to determine, since the mammogram was hard to tell exactly how much area may be involved, the breast MRI was performed, which showed that there was a larger area of involvement than either the ultrasound or the mammogram alone was able to show. And importantly, also showed that the other breast was completely normal. So another nuclear medicine type test that's used for staging how much disease is present in the breast is molecular breast imaging, and you'll hear more about that. This is just a sneak preview, more about that in this session today, and that's particularly important for patients who cannot have breast MRI, or also for patients with dense breast tissue. So now, when there is that concern for potential breast cancer spread outside of the breast to other areas of the body, this is again where we use whole body imaging. And again, one approach is with CT or MRI. And these are just examples shown here where breast cancer tends to spread, and shows examples of when breast cancer spreads to the liver, to the lymph nodes in the chest area, or to the bone, lung, or brain. Again, whole body imaging can be done with nuclear medicine techniques that use a low dose radioactive tracer. This tracer is used for bone scans, and that's used again to look, because breast cancer frequently spreads to bone. Areas that have abnormal bone activity may be a sign of breast cancer that has spread, but one which is shown in the red arrows. But in certain instances, it also shows areas that are not due to breast cancer that could be just from a fracture or infection in that instance, or arthritis. But we can use other tests like plain old x-rays and CT scans to tell the difference in that case. PET scans, again, are another way that we can look at get a whole body image to determine where exactly there was breast cancer that may have spread. And PET scanners now are combined with either a CT scanner or MRI scanner, and that information together, we get functional information from the PET images, and we can know where exactly we're looking in the body with the CT and MRI. Again, another important thing when someone's talking about a PET scan, that knowing that there's different types of PET scans, and that also is dependent on what is the low dose radioactive tracer that's used. And most commonly for breast cancer, a tracer called FDG, which is a glucose or sugar molecule that has a very low amount of radioactivity attached to it, that is looking to see where in the body is there high levels of glucose activity. So sometimes that's normal, like in the brain in this image here. Sorry, I don't have a pointer to point that out, but also can be, cancer can use sugar to divide and spread. And so those are how it shows other sites of disease for where is the breast cancer potentially spread. And then excitingly, again, as Dave had mentioned, a newer type of PET scan, which we'll talk more about in a couple slides here, fluoroestradiol. So this is, again, an estrogen tracer. So this is showing where there are sites in the body that have estrogen receptor binding. And again, this is exciting because that helps provide information on how to best treat a patient with endocrine therapy. So we're moving on to how does imaging help us pick therapies. And definitely at this meeting, you've probably heard about many or all of these different types of therapies. The ones in blue have been around for many decades, and I put in purple all the ones that have been developed and tested and moved to patients just within the time period of when I finished medical school and residency, and how much progress really has been made. And so how do you choose within all of these different types of therapies? So it's a lot of factors that go into that, and imaging is just one piece of it, together with pathology and what the tumor markers are from the tissue biopsy, and also genetic factors, either coming from the tumor itself or inherited factors that a patient may have. So again, what the exciting thing for imaging, this has been the first imaging test that we've ever been able to use for breast cancer, at least, to decide therapy questions. So again, imaging has mostly been used to localize where is the cancer spread in the body, but this tells us not only where it is, but is it likely to benefit from endocrine therapy? And these are specifically scans designed for patients with recurrent or metastatic breast cancer. And again, if there's low or no areas that light up on an FES scan, then that would mean that the patient would be more appropriately treated with chemotherapy or other targeted therapies, but not endocrine therapy. But if you see many sites of uptake with FES, then endocrine therapy would be most likely to benefit for the patient. So lastly, just look how do we use imaging to decide if treatment is working or not? And that depends, again, back to where is the disease located in the body. We use different imaging tools for early stage breast cancer. We typically, again, focus on mammogram and ultrasound, and also potentially breast MRI or MBI, which again, you'll hear more about. And looking to see if you don't see a good response during therapy, that may mean that you should try a different therapy, or when therapy is given before surgery, let's just go to surgery right away. But if you see a good response, that's definitely helpful information to help decide the best surgery plan, and then also gives prognostic information moving forward. And then whole body imaging, again, this is for patients who've had metastatic breast cancer. You can use a CT scan, which just gives you kind of anatomic sites of where disease is located, or you can use PET imaging to look more specifically at functional information. So the FDG PET, again, looking at sites of sugar utilization and active metabolism. And for patients, typically they'll look about every 3 months or so to see how well is the therapy working. And in this case, this example shows a very good response. The therapy is doing what it's designed to do, and all of the small areas of the black dots there have resolved after starting therapy. But if if your scan looks like things are getting worse, or there's new areas, then that would be a good indication to potentially change treatment. So that was my broad overview of imaging after a breast cancer diagnosis. So I'll move along to our next speaker.
Thank you, Amy. Thanks, everyone. This is a great session to be here. I'm glad to be here. I hope you're all enjoying the conference. It's great that we're starting with PET and diagnostic imaging, because that's what I see at a lot of the conference here, but we're going to switch gears a little bit and talk about early detection. I'm an associate professor at Duke. I do next generation imaging development, so that's what my lab has been doing for 25 years. But I'm going to talk about molecular breast imaging, which is something that I've had a little bit of a hand in, not the clinical side of, but mostly the development of the technology. I do have a disclosure that I'm a consultant to a company that makes molecular breast imaging equipment, and I'd like to thank the Alamo Breast Cancer Foundation, particularly Jerry Francoeur and Dr. Carol Bass, for inviting us out here for this. So let me just give you a little bit of a framework of the dense breast problem. You're probably familiar with it, but I'll just reiterate. There are BI-RADS categories for it, A, B, C, and D. It's broken up into these 4 categories, from fatty all the way to extremely dense. And as you can see in a fatty breast, it's very easy to see what a lesion might look like. But as a woman's breast is more dense, as is natural and normal, it's much harder to see a lesion. So for example, it's much harder to see a snowball in a snowstorm, right? And therefore, other imaging technologies have been developed in order to be able to more accurately and better detect any cancers that are there. Just to give you an idea of how many women this entails, there are about 57 million women that are eligible for screening every year. About 46 million or so do get screened, and about 46% of them or 45% of them have dense breasts. So this dense breast problem can actually affect a large amount of the population that goes for screening every year. That's why it's so important in order to have other technologies in order to be able to detect cancers that might otherwise be masked by the dense breast tissue. Just to go over some of the terms, I use a lot of little acronyms. You've heard these before, though. Digital mammography and digital breast tomosynthesis are the two primary modalities that are used in screening the population, whether you have dense breasts or not. And then that's usually followed by supplemental screening. And that can entail ultrasound or automated breast ultrasound, which is a newer technology, contrast-enhanced mammography, molecular breast imaging, which is our focus here today, and also magnetic resonance imaging. But I use these acronyms a lot, so I wanted you to be aware of them. Just to give you an idea of what these things can see, most of the technologies can see anatomy, as has been described, but physiology also describes or you can measure and image what's happening inside the body. And then there's also the molecular pharmacology, what's happening at the biochemical level, at a very small molecular level. Mammography mainly sees anatomy. Ultrasound can start looking at physiology if contrast agents are used. Contrast-enhanced mammography does use an injection and therefore can look at physiological aspects of what's happening. MRI starts even probing the molecular pharmacology of things. But as you see in the bottom, molecular breast imaging and PET begin at the molecular pharmacology side of things. We're injecting a tracer that has some biological reactivity, and then we trace or we image where it's actually distributed throughout the body. Just to give you an idea of how an MBI image itself is obtained, let me start with a mammogram. So here's a sketch of a mammogram. Your patient's breast is compressed between a compression paddle and a detector. X-rays from above the head shine through the breast, and you get a planar projection like this, very common. And this is an example of a dense breast tissue. So in molecular breast imaging, there are two detectors above and below the patient. But the breast isn't actually compressed. It's immobilized, and it's immobilized at about 4 times lower pressure than it would be for a mammogram. So it's really not uncomfortable at all for patients. Because the patient gets an injection, the radioactivity goes throughout your entire body, but we're really just imaging the breast. And so those two detectors will eventually form an image where you can potentially see hotspots that are not masked behind otherwise dense breast tissue that you might see in mammography. This just gives you an idea of what these MBI systems look like. They were very purposefully designed to look like mammography systems. I've learned from this conference and just in talking with many advocates around the world, really, that you don't want to be scared by the technology. I've actually talked to some women on the DoD breast cancer grant review that said, I don't want to do that because I've been poked and prodded, but I'm not going to have that technology touch me. So as a physicist and a design engineer, we try to think about how it's actually going to affect the patient who's coming in to get an exam. We don't want to cause any pain, but we want to get the best possible information that we can. Most of the molecular breast imaging systems have 2 detectors above and below, but there's also a system that's out there that has only a single detector that was formerly called breast-specific gamma imaging, but it's directly related to molecular breast imaging using the 2 detector heads. So this just gives you an idea of what the technology actually looks like. And what we're actually imaging is this molecule, technetium sestamibi. At the center of this molecule is an unstable atom. It's radioactive. And similar to PET, this directly emits gamma rays. It doesn't emit charged particles. It turns out sestamibi, or the technetium 99M, that is the radioactive atom, does emit beta particles at a very low percentage, less than 10%. But it's the gamma ray photons that penetrate the body that we can very easily image outside the body. This series of photographs just illustrates how a patient is actually oriented in the systems themselves. So in the upper left, you can see whether it's for digital mammography, tomosynthesis, or CEM, you're looking at a standard type of mammography system. Below that, there's a patient who's comfortably seated in a molecular breast imaging system. It takes about 10 minutes for each projection of the breast, and there are 4 views that are normally obtained in breast imaging, so it's about a 40-minute procedure, maybe a little bit more than that. It is less time than it does take for an MRI system. I don't know, for those of you who've been in an MRI, I've actually laid down on the tables. They're not very comfortable. They actually hurt your mediastinum. So it's something to be concerned about. Like I said, from a design engineer point of view, you want to make that more comfortable. Ultrasound, of course, usually you lie on your back with an ultrasound technologist who's pressing away at all kinds of things. So women have also expressed discomfort with the ultrasound procedure itself. Just to give you an idea of what the images actually look like, here's a slice from digital breast tomosynthesis of a dense-breasted woman. At the tip of the arrow is a suspicious lesion. But with these other imaging modalities, it's much more easy to see what's actually going on inside the breast. So with the contrast mammography, there are two images that are taken, and the difference of those images results in that vascular anomaly that's there in the otherwise dense-breasted region. For molecular breast imaging, you can see that it just lights up. The lesion just lights up. And that's the characteristic telltale sign that something's going on there because of the increased metabolic activity. The same is true in MRI, where the lesions light up. And frankly, for these three imaging modalities, we consider them vascular imaging modalities because you have to inject the patient for each one of them in order to obtain the best image. So it's not a whole body image. You're really focused on imaging the breast, of course, but it does affect your whole body one way or another. I don't want to overwhelm you with this table too much, but I wanted to put it up here just for reference sake. You can look at it again. These talks are being videotaped. And this just shows you the normalized cancer detection rate per 1,000 for each one of the modalities. Things like the sensitivity and specificity, which are indications of how well the technology actually does at detecting different cancers. PPV3 relates to the positivity of biopsy samples that are taken, and the negative predictive value essentially says that if you've got a negative scan, you've got a 99% chance with molecular breast imaging that you don't have cancer and you can go home worry-free. So these types of parameters are really good to know in terms of comparing the technologies that are out there, because not every clinic that you might go to has any or all of these technologies. And so that's something that you have to discuss with your physician, knowing that things like contrast mammography, MBI, and MRI actually have really fantastic characteristics, particularly in cancer detection rate. So just to illustrate that, I put that on a bar chart here to give you an idea of how many cancers per 1,000 scans are actually detected by these technologies. And MRI, by far is considered the gold standard, but CEM and MBI are actually quite competitive with MRI and are much more easily accessible. That is to say, MBI isn't as widely distributed as MRI is yet. There are only about 200 units here in the United States, but it's something that hopefully is going to be growing with time, especially because of the effectiveness that it has to detect cancer. So when you're talking about supplemental screening, that is screening those women with dense breasts that do need this additional workup, we could categorize effective screening, supplemental screening modalities versus these other ineffective modalities. Frankly, physicians will often say that even mammography misses more cancers than it finds, and the same, unfortunately, is true for digital breast tomosynthesis. So it's good that we have these other technologies, including molecular breast imaging. I won't touch too much about this, except the Density Matters trial, which was a multi-center trial run from the Mayo Clinic. It involved people like Dr. Rausch, who's going to be talking next, were involved in that. And their multi-center trial results are similar to the individual institutional trial results that have been done previously, showing very high sensitivities for all cancers, particularly for invasive cancers, and also showing a high cancer detection rate for invasive cancers when using either molecular breast imaging alone or in combination with digital breast tomosynthesis, which is kind of the natural way of doing things. You get that DBT, and then if you need follow-up imaging, then MBI is definitely one of those options that you could do. One of the concerns that Dr. Mankoff mentioned earlier is radiation dose. So I definitely had this slide up here. You decide if the radiation dose is too high. For a mammogram, for example, the dose is 0.7 millisieverts. Those are the units that we use to define radiation dose. For a DM plus DBT, it's about 1.2. For MBI, it's only 2.1. So while the radiation dose from an MBI scan is, in fact, 3 times higher than a molecular breast image, it's already 30% lower than what you'd get from the natural background, and it's 25 times lower than what radiation workers actually receive, could potentially receive before they're told to stop working. I just put this up in a graphic for you here so you can see this a little more clearly. The line on the far right is the annual limit for radiation workers. The bar, the gray bar towards the left side, is kind of the background that you would get just for living in the United States. You get about 3 millisieverts if you live near the coast. You get about 10 millisieverts if you're living at altitudes or near mountainous regions, just for living there. All of the breast imaging modalities that we're discussing today, including molecular breast imaging, are below that natural background. So there's really nothing to worry about in terms of radiation dose. Frankly, the American College of Radiology, the American Association of Physicists in Medicine, the Health Physics Society, the NCR, all claim that below 100 millisieverts, there's no definitive evidence that ionizing radiation actually causes cancer than would otherwise happen naturally. So if you're going to get any of these studies, there's nothing to worry about, in my opinion, and in my scientific opinion, frankly. So I hope that was clear. Sorry, I've got one more slide here about contraindications. So I did mention to you that each one of these vascular imaging technologies requires an injection. They also come with some contraindications. The only common contraindication is pregnancy, whereas the others have a variety of things you need to be careful of. If you happen to be allergic to shellfish, if you have diabetes, if you're claustrophobic, or if you have hypertension, these are things that you need to be careful of. You're going to be queried by the physicians or medical staff if you've got any of these issues. I will point out that the only contraindication for molecular breast imaging is pregnancy, and I will also point out that all of these are considered safe for human use by the medical community, American Medical Association on up. So again, all of these modalities are viable, and I just want to point out that molecular breast imaging is one of those nuclear medicine modalities which can actually make a benefit to women with dense breasts. So thanks for that. I hope it was clear, and even if it wasn't, I look forward to discussing more of this with you later.
Okay, thank you. Okay, thank you, Martin, for excellent presentation about molecular breast imaging. And I am going to continue on the same subject. Let me introduce myself. My name is Maya Rausch. I am professor of radiology at UT MD Anderson Cancer Center. And my area of expertise and interest is functional breast imaging, advanced functional breast imaging for women who, for diagnosis and screening, diagnosis, and treatment response prediction for patients with breast cancer. And my talk will be again about how we use molecular breast imaging for screening and diagnosis of patients with breast cancer. And first thing that I want to reiterate is mammography, is only imaging modalities that proven to decrease mortality in breast cancer. So we should not ignore mammography. All women, we need to get mammography. That's really important, and we should not forget about that. However, as we already heard multiple times, mammography has its limitations, and the main limitation is in women with a dense breast tissue. As you can see, sensitivity of mammography significantly decreases in women with a dense breast. And you already saw the similar slides. And again, this is, as mammographer, what I look when I read mammograms. And here's the first patient. You see this fatty breast. You see black breast. And you see this white tumor. Easy to see. You don't need to be actually, radiologist to see it. Yes, here it is. White on the black. And here are these two women, dense breasts. They do have cancer. But seeing white on white is very difficult because their dense breast tissue is white. Cancer is white. Here are their cancers, but seeing them on mammogram, practically impossible. And this is a limitation of anatomical imaging. And this is why I need additional imaging techniques. And which imaging techniques would help? Functional imaging. That's all what my colleagues have been talking about within last hour. And molecular breast imaging is one of the breast imaging modalities that is definitely helpful for specifically, especially for this category of women. By this time, you already should know this answer. I think Martin gave excellent overview of molecular breast imaging, so you are experts. We know that we inject technetium sestamibi. Fun fact, actually, sestamibi, originally was developed as cardiac imaging agent. For stress test, when they want to determine if your arteries are blocked, and they put you on the treadmill and you run on the treadmill. So after that, they put you under the camera and image the heart to see, how heart is perfused. And this is how it was found that when they imaged this patient for cardiac problems, they found that actually systemic was accumulated in breast cancer patients. They were able to find breast cancer. And that's what gave birth to molecular breast imaging. And this is like old detector. When they use this huge detector, you can see the breast is tiny there, so not much you can see. And that's why now, as Martin described, we have all these newer specific detectors that are designed for breast. And you see these images. They look like mammograms, exactly, but they are not mammograms. This is not anatomical imaging. This is physiological imaging. We see how this tracer distributes in the breast. Martin touched about how we image them. Again, we inject very light compression to the breast. It takes like 2 views, like with the mammogram, CC view and MLO view, 40 minutes, comfortable sitting position. And this is, I wanted to show you our MBI room. As you can see, we have TV there. Because procedure takes about 40 minutes, and we want to make sure that our patients are comfortable, sitting for 40 minutes. So patients can watch their favorite soap operas, CNN, ESPN, whatever they desire. It's there. And these are our MBI technologists whose only job is to make sure our patients are comfortable and we get good quality images. And here I wanted you to show the mammogram that is kind of double whammy, because this woman not only has a dense breast, she also has breast implants. And that makes our job as radiologists very difficult, and our technologists to position. What do we do for women like that? Our technologists have to pull breast, push implant, and take image of the breast. This is what you see on the right side, okay? And mammography is not most comfortable procedure. But imagine that in addition, they are pulling, pushing, and taking these images, okay? And here is the same patient, molecular breast imaging. No pulling, no pushing, gentle mobilization, no pressure. And this blackened part in the middle, this is some kind of attenuation because of the implant, but we still can see through the implant. So if there is a tumor, we will be able to see it through that area. So, I just kind of wanted to show you that that's one of the another advantages of molecular breast imaging. So bottom line, again, I'm reiterating again that all imagers here have been talking about mammography, anatomical imaging modality, has limitations when MBI, functional imaging modality, about physiologic processes in the breast, and they are not influenced by dense breast, by scars, by implants. That is one of the major advantages of these physiologic imaging modalities, such as MBI. There are multiple indications for MBI. I'm not going to go through all of them. Just a couple of them, actually 3 of them. And number 1, screening dense breast. Martin already talked about it, but you cannot talk enough about that, I think, because it's really very important and big issue, actually. For increase, what I have, I work at MD Anderson, I have been seeing increased rates of cancer in young women. Something that was unheard of, 20 years ago. I see 20-year-old girls coming with breast cancer, and majority, especially younger populations, they have more dense breasts. So that's definitely, big issue to how to evaluate this woman with a dense breast. This table is a bit complicated, but practically the main reason why I'm showing it to you is just list some clinical trials and studies that evaluated how molecular breast imaging can help to detect breast cancer. And on the red, it's incremental cancer detection rate, which means how many more cancers are detected by molecular breast imaging that were not seen by mammography. And data for invasive cancers, and you see the different studies showed from 5 to 7 extra cancers were detected per 1,000 of women with use of the molecular breast imaging. And this is density matter clinical trial that just finished enrollment. It is led by, and I'm honored to be part of this multi-center screening trial that is led by Mayo Clinic. And the reason why this trial was designed and the main goal of this trial is to evaluate and to see and compare how many more cancers molecular breast imaging can detect, invasive breast cancers, which are kind of more advanced, yes, in comparison with digital breast tomosynthesis, which is now practically, standard imaging for screening. So we enrolled 3,006 women with dense breast, and all of these women had both molecular breast imaging and digital breast tomosynthesis. And these are preliminary results that just were presented last week at RSNA. This is our large radiological media meeting, and first time these results were presented. And I'm just going to show you one thing there. Again, this incremental cancer detection rate, which is in yellow there. Again, this is how many extra invasive cancers were detected by molecular breast imaging in comparison with digital breast tomosynthesis, practically 5 in 5 women, 5 per 1,000 women, and that's a large number. And here is an image from one of our patients. And this is mammogram, again, dense breast, a lot of white. It was read as negative mammogram. And here she comes for molecular breast imaging, and you see this white with red arrow on it, that's her cancer. So we did ultrasound, we biopsied it, it was invasive ductal carcinoma. Another important indication for molecular breast imaging is breast cancer staging. And Amy talked about importance of breast cancer staging, so we need to know how much of the breast is involved, we need to know if it goes to lymph nodes or to the rest of the body. Molecular breast imaging can help to determine extent of the disease with the breast. So how much, because you can have here is the images from AJCC of breast cancer staging to determine, if it is just one tiny nodule in the breast, or if it involves entire breast, or if it goes actually maybe even in the chest wall. And that's all is very important. This is from T1, T4. We thought we'll go by 1, 2, 3, 4, because that determines, again, treatment strategy. If it is tiny nodule, patient can go directly to the surgery. If it is a huge involvement of the breast, patients treated with neoadjuvant chemotherapy. It's a treatment, chemotherapy, immunotherapy, or targeted therapy given with goal to shrink tumor, so then least invasive surgery can be done. And here I want to show this, images of patient who came to us at MD Anderson, young woman, 38-year-old woman who had recent mastopexy, breast reduction surgery. And she has dense breast. She had this palpable nodule, this white arrows and triangle, it's a palpable area that we did mammogram, and what we saw in mammogram was some calcifications which are benign. We call them fat necrosis calcifications because we see them very often, especially after surgery when, fat dies and this benign calcifications develops there. So we are okay, we did ultrasound, again, we confirm the 7 o'clock palpable, it's benign, fat necrosis changes, but at 9 o'clock, something that does not look normal. It's very ill-defined. It looks suspicious. So we biopsy. It was invasive ductal carcinoma. We need to stage this patient. We did molecular breast imaging. And here, look, you see her left breast, which is completely clean. You see, it's just all homogeneous, nothing. And look at her right breast. All of these multiple black areas, this is all abnormal. Right should look the same as the left. That's left. That's what I want to see, clean. Nothing there. And here are all of these abnormal masses that we brought patient back and we biopsied, and this patient had multicentric invasive ductal carcinoma with the CIS. So whole entire breast was full of cancer, so she had to undergo mastectomy actually because of this finding. Another important indication for molecular breast imaging is surveillance, and I assume this is for majority of women here, yes, women who had history of the breast cancer, and now we need to follow them just to make sure that there is no recurrence. And here I'm just going to show I'm showing like demonstration of segmentectomy because of the advances in the imaging and advances in neoadjuvant treatment. We diagnose patients early, and with the neoadjuvant chemotherapy, we also shrink cancer. So when it used to be mastectomy, that's what majority of women would treatment receive, just whole breast would go out. Now we can do, our surgeons, not we, but our surgeons can do just segmentectomy, breast conserving surgery, lumpectomy, it's all the same. Just take small part, and woman still can keep her breasts, and there is just residual scar. And job for us or radiologists is to image them, follow them, make sure there is no recurrence. And it can be challenging. In this case, like again, I'm going to show you patient from MD Anderson who we've been following for years for the history of breast cancer. And you see there is mammogram, you see surgical clips, we see scar, all of this white stuff, that's actually scar. And then there is ultrasound, and we see again the scar, and we kind of compare, make sure it does not change, and it all was stable over years in this woman. We recently got MBI. We decided to do MBI on that patient, and we saw this abnormal uptake. We should not see this white stuff. It should not be there. It should be all same. There should not be any abnormalities. So we brought patient back and biopsy her scar, and it turns out she had recurrence in her scar that we were able to detect very early thanks to molecular breast imaging. Because again, scar can hide cancer. It's difficult. Detect it, at very early stages. And this is where molecular breast imaging comes to help to find this abnormal uptake. I want to briefly talk about cost, because that's important. Yes, cost effectiveness, it's really very important. And there was a study performed that compared BSGI, which is molecular breast imaging, but just with one detector, and found that actually, cost of the BSGI versus MRI was significantly less. BSGI was about $850. Now, actually, it's even less than that. It's like $600, how much MBI costs versus MRI over $3,000. And it's just like quarter of the charges of MRI, while performance in breast cancer detection and staging was very similar. And there is another paper by Dr. Hruska from Mayo Clinic who showed that cost per cancer detected was lower for the combination of MBI and mammogram than for mammogram alone. Reimbursement, that's important issue because we don't want our patients to get stuck with a huge bill. And it currently varies between commercial insurances, and usually pre-approval is needed before the procedure. Major insurance companies usually cover MBS as adjunctive diagnostic modality. For screening, it's not universally covered, and that was main goal of our Density Matters clinical trial, to show effectiveness of MBI so that insurance companies will cover screening MBI, and hopefully we will be able to pursue them, to cover MBI for screening. And this is just a screen capture from the website for Society of Nuclear Medicine, where is a directory where molecular breast imaging sites are available. They are not universally available at this time. And if you are interested, this way you can go. Find sites. Currently, there are 18 states and 31 states that have MBI imaging available, and this is a list of the states. And Texas, we do have this available in Texas and in many other states. So hopefully, I was able to show you that molecular breast imaging is a functional imaging that can be used for screening, for diagnosis of patients, especially with advanced breast. It is really well tolerated. It has low cost, low complexity, and I hope that it will get more and more available for women around the country. And now I'm going to pass to Leslie to talk about, dense breasts.
Thank you so much. Let's see. My name is Leslie Ferris-Yerger, and I am CEO and founder of My Density Matters. We empower women to find out their breast density and learn their options and advocate for themselves, because right now, as we all know, these additional screening modalities that find more cancers that women need to make sure they find their cancer early are not readily available, and we intend to change that. So we envision a world where breast density no longer hinders the early detection of breast cancer, and right now it does. I hope that's clear to you by now from the previous presentations. Just a little bit of back history, how this all came about. I was diagnosed with stage 4 lobular breast cancer 2 months after an all-clear mammogram and ultrasound in November of 2017. And I know now that I'm not the only one that this happens to, and it happened because I had dense breasts. In September of 2018, I embarked on the mission of my life, and I walked all the way across the top of Spain, started in France, walked all the way across, took me 40 days, and while I did that, I raised money for the Density Matters trial. And so it's a bit of a moment. I'm having a little bit of a moment right now because I never really thought that I would see the results of these studies. And so it's fun to see you guys present the results of the study and that it is so good and it's going to help so many women find their cancers early, well, more curable and just better for their life. Wrote a book about it called Probably Benign, and it is really just a story of hope and a wish for a better tomorrow, so that one day our vision is achieved where no woman is left behind because she has breast density and has to suffer a stage 4 diagnosis like I did. We've covered this readily today, but this is the image that you will see all over social media from our organization, My Density Matters. We tried to take a complicated topic and make it as simple as possible, yet factually true, to convey to the world what is really going on. Because really right now, most women don't know about breast density. They don't know if they have it. And so we need to come up with ways to do that. So it's kind of a simple slide. We've seen it before. Now you see it on the left where you're not a dense breasted woman, category A, category D, now you don't. Now you see it, now you don't. Breast cancer masks. No, breast density masks breast cancer on mammograms. And also, it's an independent risk factor. I think that's a newer finding. A woman with extremely dense breasts is 4 to 6 more times likely to get breast cancer in the first place. Double whammy, just that little extra insult to injury. 71% of all breast cancers are in women with dense breasts. That says something just by itself, does it not? So how do we move the needle? We're all still getting mammograms. Mammogram is still the gold standard for everyone, not just those women with dense breasts or those women without dense breasts. So what do we do? How can we get everyone getting the additional screening they really need so that my story does not ever become anybody else's story? Well, that rock is huge. And this poor guy is not going to move that rock by himself. And when I first started this work, I worked with a radiologist, and he said to me, if you women want this changed, you're going to have to make it happen yourselves. Otherwise, things might just stay the same. And so my response to that was, okay, game on, let's do it. And so My Density Matters was born almost 3 years ago now, still pretty new. We're not going to solve this problem right here today. And it would take a whole conference, as long as SABCS is, to cover all the things that really need to happen. So we're asking for 3 very simple things today to help us move this needle along. Number 1, it's about you. Find out your breast density if you don't know it. Women are so notoriously terrible at putting themselves first. We all put everybody else first. Take this one time to find out your breast density, make it a priority, and take appropriate action. Consult My Density Matters about what else you need to know. We've got downloads, we've got all kinds of things on there that can help you get what you need ultimately. So, number one is you. Number two, we are having a very, very big day on February 21st. It's actually our 4th time of doing it. We have something called Find Out My Breast Density Day. And it's February 21st, and we'd like you to join us and help us spread this information around the world. I can't go into all the details now. Find us on social media, follow us, it'll be all over that. Contact us, get on our mailing list, join us. You could have a watch party with your organization, you could share it with your friends. There's any number of ways to get involved. So please, join us on February 21st. Find Out My Breast Density Day. And number three, one of the barriers that we have with this is that a lot of these additional modalities are not covered by insurance in any kind of standard way. And so we're trying to fight that battle. It's gonna be hard, it may not happen soon, but again, like that radiologist told me, that rock is not going to move by one single person trying to push it. It's going to take all of us. So I have two things that you could do here. You could ask your congressman to co-sponsor the Find It Early Act. That is a bill that has been introduced that calls for the zero cost sharing for additional screening for women with dense breasts. What a difference it would make. If these additional screenings were actually paid for, they would start to be used more women would find their breast cancer early. So my story does not become anybody else's story. That's what we need. So we have a QR code there, and that's an easy and simple way to write to your congressperson. There's also a petition. We have 25,000 signatures on it so far. Please use the QR code and sign the petition. It's literally 30 seconds of your life, and it will make a difference, and our voices will be heard. So I just want to say thank you to the scientists here and the doctors that are studying this and making it so that we can all benefit from it. But what has to happen is we need to take this science and this technologies available to everyone so that we can reap the benefits that they have found that are true. So, thank you very much.
We're going to open it up for questions now. How many minutes do we have for questions?
10.
Okay, thanks. We have 10 minutes for questions.
Great.
And I can't see.
No worries. My name is Heather Porowski, IBC Research Foundation, board member, founder of Hoosier Breast Cancer Advocate, project lead graduate, and I'm a Cancer and O-negative blood, so I got you. I think that we can possibly all agree that the first medical relationship that we have as a woman is with our OBGYN and gynecologist. And so it's extremely concerning. And to me, that as I continue to go to these conferences and so forth, that there is really no presence of OBGYN and gynecology, especially when they're the ones that are treating. And honestly, they don't get it, right? So when I say that mammograms don't work when you have dense breasts, and I try to advocate to my friends and family, my circle, they try to get that additional diagnostic testing, and the OBGYNs look at you like you have 4 heads. That is why we have a state bill that is going to be introduced in the next legislation. And I think it's the reason for this, if I can say this. It's ACOG, which is the American College of OBGYNs. I just want to read to you their statement on dense breast and additional diagnostic testing that is right now on their website. In the state, this is our position. In the states, ACOG advocates against legislation that prescribes what must be communicated to patients about breast density and cancer risk, especially when the information is contrary to evidence-based scientific data and medical consensus. There is no reliable, objective, and quantitative method for assessing breast density. No clinical guidelines recommend additional screening solely on the basis of high breast density. And breast density is not a major cancer risk factor.
Wow. Who's going to take that one?
If I can say
if we're talking
something-
about diverse populations, rural communities, okay? This is the collective field that is killing us. It is ACOG and OBGYNs and gynecologists by not informing us. And if they have this stance on their website and they're the ones that are blocking legislation and we're not talking to them because they do not know the billable code for additional diagnostic testing, shame on you. So, what are the oncology community willing to do to truly help us? Because it's not working and they're not working for us.
If I can comment on that, the Find It Early Act actually does have a lot of antagonists, and it is really up to us to push that forward, because you would be surprised at how, I can't see, how many really are against the Find It Early Act, and we really need to get a grassroots going to get it passed.
ACOG specifically, right? Because that's, if you look at your OBGYN gynecologist, they're a part of this. They're part of this. And so what they're doing is they're not asking, they can't identify and go against, especially when they are the fellowship and receive funding for their practices. ACOG is, that's the one I know, and you can go through, but that's what we need. And how are we supposed to go through when the oncology, departments aren't talking and they're not showing up to this? What would you suggest, especially when we talk to our OBGYNs, right? And we talk through, what can we do?
That's a very hard question, actually. I didn't realize that. I'm actually shocked to hear this, because we as imagers have been talking and advocating for dense breast and for a need of additional screening for this woman. But that again shows that within the medical community there is not enough congruence in their acting. And this is something that we need to work at. Thank you so much for bringing this to our attention. And what I personally can do, I will bring to our Society of Breast Imaging and bring these questions that you raised and see how we can develop some kind of relationship with this ACOG and shows them what needs to be done in order for us to show them for need to address this important question. I don't think, because that's unbelievable. That's unbelievable. But again, as Jerry said, there are a lot of people who do not. What we're talking about, there are people who don't think people need to do mammography. So if we go there, there are samples that,
But let's hit ACOG first.
Yes, I agree, but.
Let's get ACOG first. Thank you.
So maybe with the new Density Matters trial results, which are this multi-institutional clinical trial, that would be definitive evidence that things like MBI used in conjunction with tomosynthesis are actually viable. Prior to that, there were single institution studies. So there's plenty, which basically show the same results. So the evidence is already out there, but there is some selectivity from these societies as what they consider to be current literature. Sometimes they only have a 5-year look back every time they make these types of blanket decisions. I will also point out, so that's relative to ACOG. I will also point out that there are 24 states in the United States so far that do have insurance coverage for supplemental screening. So usually the terminology is that it includes ultrasound, MRI, and other technologies, and those other technologies are usually condoned by the National Consortium of, National Comprehensive Cancer Network, so the NCCN. And the NCCN now has thrown out DBT and ultrasound for use in dense breast women and those with other risk factors, and has included MBI and CEM as the two modalities to replace those two. So, provided those states' laws actually abide by the NCCN guidelines, there should be insurance reimbursement for it. The Find It Early Act that Leslie was talking about, and these other efforts that we're actually trying to do, talking to ACOG, talking to the ACR to accept MBI, those are multifaceted ongoing efforts to try to get them to agree that, look, the science is here. It's pretty clear. Now you just have to change your clinical practice and actually, enable it, perform the supplemental screening.
Standard of care. Yeah. I'll just reiterate again what I said before. This is not an issue that we as advocates can let go. We can't leave it up to anybody else to do this for us. We have to get behind this and make it happen. Otherwise, it might not. And it's killing us, as you said. Yeah.
My name's Naomi John. I'm the Vice Chair of the Inflammatory Breast Cancer Network in the UK. First of all, thank you for taking the time to explain to us really complicated physics. That enables us to be able to go back to our support groups and explain that to our girls who just don't have a clue what's happening with them and what these tests can show them. So thank you. And also, I'm sorry I forgot your name. I'm going to take your February date for your density matters back to the UK. I will share that with the other breast cancer charities in the UK, none of whom are here, which I'm quite surprised about. So that's something I'm also going to take back.
Wonderful.
It's kind of a question, and I'm sorry if I put you on the spot with this. So for inflammatory breast cancer, we have a bit of a double whammy because we've already got a candy floss presentation, double that if you've got a dense breast. So it's really difficult to read our imaging. And I don't know whether the panel are aware, but there's a small team at Birmingham University Hospital who are looking into the use of thermography to support treatment, whether the patient is on appropriate treatment. And so they are using thermography because as inflammatory breast cancer patients, we've got hot breasts and not in a good way. And that heat mapping, what they're hoping is that they'll be able to see whether the treatment that the patients are receiving, whether the patients are responding appropriately to that treatment. And I wondered whether anybody on the panel, I know that thermography often gets dismissed, it's not validated, it's a bit hocus pocus, not healthcare professionals, but whether you have any information about the use of thermography in a positive way to support particular cohorts of patients.
So the one thing that I'll say is there is been a call for having more of a bedside type approach for being able to measure response to the breast in the setting of treatment, including breast cancer therapy. There have been a few early publications in optical imaging, which is nowhere close to moving forward, but with the idea that you could have a bedside technique that would identify this. And some of the parameters that they're looking at, I can imagine being associated with some of the temperature you're looking at. I think the problem is thermography has been tried back and forth over the years for screening and really has failed pretty much every single time because it's probably not particularly sensitive. And so there may be some lessons from what you're talking about that can enable some of this other bedside technology that is looking at somewhat similar parameters. But these are still pretty early in the effort. We conducted a study in Akron using the optical technology, which looked very promising in certain ways, but it hasn't really made it into the mainstream at this point. Beyond that, I'm not sure I can comment on thermography other than there's pretty definitive evidence that as a screening technique, it's not going to work as well as these other components.
Yeah, absolutely. Like as screening diagnostic, not appropriate, but whether there is a merit for it in a supportive fashion for patients who have already received a diagnosis, particularly of inflammatory breast cancer. Thank you.
Okay, I'm sorry we're at a hard stop. They'll be around for a little bit if you have any other questions that you want to discuss. Thank you guys all for being here, and I hope now that we have got an imaging into the conferences, there'll be more and more imaging, which will help us get what we need. So stay tuned, and please come back later this evening for our hot topics. I want to thank our sponsors once again: Exact Sciences, Genentech, Merck, Novartis, Daiichi Sankyo, GE Healthcare, Menarini, Stemline, Seagen, Lilly, Pfizer, Eisai, Viatris, the Joe W. and Dorothy D. Brown Foundation, the Carpenter Foundation, and our production company, CMP. Thank you guys so much. How did that work?